Welcome everybody to the Francisca Genitourinary Oncology Tumor Board. My name is Brian Reaney. I'm a professor of medicine at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And I'm pleased to be joined today by a panel of experts, and we're going to talk through a number of kidney, bladder, and prostate cancer cases.
My name is Jason Abel. I'm a surgeon. I'm a urologic oncologist and associate professor at the University of Wisconsin.
My name is Maha Hussain. I'm a GU medical oncologist. I'm a professor at the Robert H. Lurie Comprehensive Cancer Center, Northwestern University, and I also serve as the deputy director for the Cancer Center.
Hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I specialize in abdominal and pelvic imaging as well as nuclear medicine. I'm glad to be here.
My name is Preetash Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University, focusing on GU malignancies.
A 79-year-old Caucasian male diagnosed in 2004 with Gleason 3+3 prostate cancer and underwent brachytherapy. Several years later, 11 years later, this patient had progression as manifested by a rising PSA and bone metastasis and initiated androgen deprivation therapy. 2 years later, had further progression, and genetic testing at that time showed a BRCA2 mutation. 2004, diagnosed with low-grade Gleason 3+3 prostate cancer, got brachytherapy. No other information around hormone therapy at the time, but presumably just brachytherapy. Did well for many years with a PSA nadir, and then 11 years after brachytherapy had a rising PSA with repeat biopsy showing now high-grade Gleason 5+4 prostate cancer, and imaging showing uptake in his left inferior pubic ramus, and the patient was initiated on androgen deprivation therapy. And I actually want to pause there to talk about this patient as they were in 2015. So I'll actually call Dr. Fromm, if you don't mind commenting a little bit about this patient. Presumably had conventional imaging in 2015. So let's ignore the year for a second and pretend that that was today and we had access to the full spectrum of Oxamin and PSMA and other PET scanning. Is this a patient where, and I'd love for the others to comment as well, is this a patient where we would routinely do PET scanning if the conventional imaging only shows one area?
Yeah, so I'm assuming that the uptake that's described in the left inferior pubic ramus is on a conventional bone scintigraphy examination, sure. Which is fairly specific when it does in fact show a lesion, but isn't nearly as sensitive as some of the newer imaging techniques that we have to offer in the setting of recurrent prostate cancer. So it really, I think a lot sort of depends on, insurance algorithms and reimbursement patterns in terms of what we can get approved. But our preference is always to have, if possible, an FACVC or choline PET CT, or, I think in the very near future, PSMA PET is going to be much more readily available, just because, the treatment for oligometastatic disease with a single site versus much more widespread disease, as could potentially be detected with one of these more sensitive imaging modalities, could pretty dramatically alter the patient's management.
Thank you. And Dr. Hussain, do you mind commenting if this patient did get, let's say, a PSMA PET, which to my knowledge is the most sensitive of the modalities, of the PET modalities, and it was just this one site, so rising PSA, remote local therapy, and now just one site based on advanced imaging? What would be your approach in that patient?
I think the fact that he has metastatic disease, from my perspective, really makes it important to discuss with the patient options of management. Certainly in the context of very limited disease, low volume disease, or oligomets, in this case, an isolated bony lesion, if the patient does not prefer to go with systemic therapy, certainly focal radiation to that area is a potential. I want to highlight always, and that's my discussion with the patient, there is no data to date that says actually focal radiation alone is a life-prolonging approach. So essentially, it kind of buys you some time in terms of not starting systemic therapy. My general discussion with the patients, and in this case, this patient was, in fact, what is the goal of treatment? The goal of treatment is prolonging life. And if that's the goal and reducing the chance of morbidity related to cancer, then really maximizing the management strategy would be appropriate. Now, in 2015, the whole concept of radiation to oligomets was sort of not exactly something that was very common. And so certainly systemic therapy would be the approach. And of course, this is predating much of the data on therapy intensification timelines.
Yeah. Yeah, and it was sort of mixing the years here, but I thought it's very relevant and something that
Absolutely.
I think comes up a lot.
The one thing I should also mention, I have had situations where lesions like this were looked at and were deemed not very, very suspicious. And so I would say this lesion in the context of a rising PSA, if the radiologist interpretation was that, well, I'm not really sure, this could be this or could be that, not 100%, I have actually put patients through biopsy to confirm, partly because you're committing someone to potentially very long period of treatment with all of the physical and other pressures that could come from the treatment.
But just to maybe summarize, if this patient had biopsy proven or definitively radiographically proven solitary met, you would consider radiation and then observation until further progression.
I would discuss that as an option, but that would not be my preferred route. My conversation with the patient puts in the big picture. This is not about delaying treatment. The question comes up, what is the goal from the treatment? And if the goal is to try to maximize the chance of putting the cancer into remission for longer periods of time, then my approach would be actually systemic therapy complemented by focal radiation.
So both, okay, so
Yes.
both. And Dr. Patel, do you want to talk about focal radiation in prostate cancer? I guess, there's a moving target of what represents oligometastatic disease. I don't know if you have an opinion on the role of radiation in solitary mets or oligomets, maybe generally speaking.
Yeah, thanks, Dr. Rainey. An important area. In this case, just to touch on some of the nuance here, I think it's maybe a little unclear as to where this biopsy was done. And that I'm saying that because this patient's been previously irradiated to the prostate, and if we don't have control of the local disease in the prostate, that's a totally different situation. And I think some of the newer data using focal radiation for metastasis does not apply really for someone who has recurrence in a previously irradiated field. But in a different situation where there is confirmed oligometastasis, the trials that have been done have used different sort of numbers of lesions. And of course, many of these trials were done prior to the advanced PET era. I think it's reasonable to use 3 lesions as sort of a limit. That's what we typically use and what's been used in the trials. And I think as Dr. Hussain has already mentioned, the outcomes on these studies are really, they're not sort of survival studies. These are smaller studies, and the outcomes we've looked at are progression-free survival, and in some cases, ADT-free survival, which is really more of a quality of life endpoint. So these are important endpoints, certainly, but I think, the group is right on in terms of the fact that overall survival certainly has not been studied in this situation. That being said, I think we've got great technology to be able to do this safely in most situations. So the pubic ramus in particular tends to be an area we can treat effectively and safely without a lot of high-risk toxicity. And so for some patients who are motivated maybe to delay the onset of systemic therapy, it makes sense.
Okay, thank you. And yeah, I assume
Can I ask a question maybe?
Sure.
To Dr. Patel? So Dr. Patel, I have a fair number of patients who have had brachytherapy previously, and then they present back with local recurrence. So this biopsy was actually from the prostate. So this is the Gleason 9 is driven by the prostate biopsy. And I guess the question is situations where, like this gentleman, would you ever reconsider, if we're going to target the bone with radiation, understanding that it's not always easy to re-irradiate a disease, a tissue that was radiated, would you be able to re-irradiate the prostate actually to try to maximize the benefit there?
Great question, Dr. Hussain. I think as radiation oncologists, we really sort of try to weigh the risk and the balance, the risk and the benefit. In a situation where the benefits that we've thus far seen in the small studies are not overall survival type benefits, when we start to get to a position where the risks become more significant, so re-irradiation to the prostate certainly carries much more risk than SBRT to a de novo metastasis. We tend to be, very unlikely that we would offer that patient radiation to either of the sites because it's unclear if you have untreated local disease, if ablating a single metastasis really makes a difference. And again, the trials have not included patients like this.
Yeah. Thank you. Good discussion. So we're going to move on. So this patient, remember, was started on androgen deprivation therapy. This is all happening before the era of PET imaging and the oligometastatic discussion. So patient was started on ADT for prostate cancer metastatic to bone, has a response for 2 years, then has a rising PSA. Repeat imaging shows, again, that left ear inferior pubic ramus lesion. The patient gets palliative radiation at this point to that area, and then also gets a bone biopsy at this point that shows a BRCA2 mutation. So Dr. Hussain, I'm going to ask you to comment at this point, I guess, about two things. One is, when do you do genetic testing in your prostate cancer patients? Is there a typical time, that sort of that you do in the course of taking care of these patients, or is it patient specific? And then you were very involved in a lot of the PARP inhibitor trials, and I want you just to give us an overview of that as well.
Absolutely. I think obviously in that era, in that time, it's a different story. In the current era, when I see somebody with either de novo metastatic disease or metastatic disease that's high volume, I tend to discuss with the patients the option of next-gen sequencing, and definitely germline testing. And part of the reason is more like to prepare for the next step. These are patients who have clearly high-risk disease, and certainly with the castration-resistant patients, the options of targeted treatment and or clinical trials that might be looking at targeted therapy based on NGS is going to be critical. Definitely in situations at the time, in this case, was more of trying to evaluate the patient for the potential of clinical trials. And so that's what prompted that biopsy. But as I said, right now, I would generally do it in de novo metastatic disease, in patients with early castration-resistant disease, or patients who come in with high-risk disease at a very young age. And I think these are the different criteria I think applies there.
Okay. And then if you could, actually, let me just go to the next slide. So this patient was—
point out one thing.
Sure.
One of the advantages, and we can discuss that later, one of the advantages of doing the NGS earlier, so this is the tumor, next-gen sequencing, is that the older the tissue, the yield of the tissue may, if it's archival, the older it gets, the value of it goes down in terms of quality for subjecting it to NGS. And so sometimes it's actually also more of a tactical strategy to try to get the data available for future use.
And thank you. So this patient was enrolled in a trial at the time, which was evaluating Abiraterone, Prednisone versus Olaparib, which is a PARP inhibitor, versus the combination. He was randomized to the combination and responded. And Dr. Hussain, it might be a big topic, so if you give us sort of the Reader's Digest version of what is the current proven role of PARP inhibitors in CRPC?
Well, I think, as you know, last year was a remarkable year for prostate cancer, specifically when it comes to precision medicine and targeted therapy, because up until now, for a variety of tumors, the concept of targeted therapy and precision medicine has been part of standard of care for a long time. And prostate cancer, this actually emerged based on 2 FDA approvals that occurred summer of last year. One based, the key trial was the phase 3 trial that looked at Olaparib in patients with castration-resistant prostate cancer, which demonstrated a progression-free survival improvement, but also we reported an update on overall survival improvement.
Thank you. So yeah, as you say, 2020 was sort of the year of PARP inhibitors and prostate cancer. It was really sort of the first genetically targeted treatment in this disease, to my knowledge, right? Yeah. So fast forward now 2 years after this patient goes on trial and is responding to this combination, has unfortunately a further rise in PSA, new hip pain, bony progression, and also soft tissue metastases. So I guess the question is around, rebiopsying to determine the genomic profile, i.e., has that changed since the previous tissue analysis? Dr. Hussain, do you routinely do that in these patients?
I don't generally subject patients to biopsies unless our hands are tied, so to speak. So this is a gentleman who has options in terms of standard of care. and many of the lines of standard of care are available for him. So I think that would be one option for him. The other fact right now, we have actually the cell-free DNA opportunities to look for potential, again, new NGS type, opportunities for the patient. So at this moment, I would say, unless there is a reason, let's say he's not eligible for chemo, not eligible for radium, not eligible for other standard of care treatments, I would generally not put him through a biopsy at this moment.
And so just to reiterate some of what you mentioned for standard of care, chemotherapy, taxane would be probably standard chemotherapy.
Correct.
Radium, although we're told the patient has some soft tissue disease, so
Correct.
depending on the extent of soft
Correct.
tissue disease. How about CIP-T? How about immunotherapy? Would that be an option in this patient?
I have to say, it certainly is an option, and if the patient is asymptomatic, is to be discussed. I probably should declare my lack of what is the word, belief in the
Enthusiasm.
Let's say I'm not a SIP fan. Yeah. Part of the problem is, I think, the totality of the data and how you interpret the data. And also in situation like this, where this is a patient who has progressed on, frontline treatment. If you think of the original SIP data was really frontline castration resistant, this is not frontline castration resistant and so on. So I tend to go with stuff that I feel is absolutely not, there's no question about in terms of the value of the treatment. But certainly I think part of the discussion is discussing the potential for SIP, or as I said, clinical trials if the patient is interested and eligible. Patients who tend to be symptomatic, and again, that to me makes a huge difference. Asymptomatic patients, there is a window of opportunity. Symptomatic patients, generally, you'd want to, my humble opinion, go with things that you know have a better chance of working.
Yeah, fair enough. So just to summarize, there's a lot of complexities to this case. I promise they won't all take this long. We said probably wouldn't biopsy routinely in a progression state unless there were certain risk factors or certain reasons to believe maybe other trial opportunities would be one of those reasons. And then in terms of next steps of treatment, probably chemotherapy and radium would be probably the most standard, maybe depending on patient preference or symptomatic disease. And there might be some other ones like Sipuleucel-T, et cetera, for more asymptomatic, maybe even for more indolent disease.